Welcome to Malpractice Podcast.
Me? You? Are you ready to get started?
I'm ready.
How are you doing?
I'm good. Oh, I'm Jess.
I'm Sydney.
And this is Malpractice Podcast.
We're here. We're in the mix. We're back from a brief hiatus, right? It feels like it's been a while since we recorded.
No.
No?
No.
Okay.
It was, we put something out last week.
Oh, yeah. Okay. No, just weeks take 12 years now for me.
Yeah.
Okay, perfect.
Yeah, that's true.
Okay, well, then we're back here on a regular schedule.
Yeah, we're back here without delay.
But you got to take a little vacation in between.
Oh yeah, I went to Colorado
Mm-hmm.
and I went skiing.
I do feel like couples should be able to take a honeymoon every year. What do you think about that?
I think you just call that vacation.
Yeah, but if it's a honeymoon, you get perks because you get to tell people like, oh, we're on our honeymoon. You can just do that. You don't have to actually be on your honeymoon.
Yeah, you could just lie all the time.
Yeah, that's where I'm at, I guess. I just want to lie more.
Okay, that's fine.
Cool. Did you see my face?
What happened? Yes, I did.
Okay. I was in a hurry to curl my hair on Sunday, inexplicably, and
She's burnt her face.
I zapped my face with a curling iron.
Oh my God.
Like a branding iron. It's like I branded my face with a curling iron. It's not a good look.
It doesn't look bad. It just looks really intense.
It looks like a burn on my cheek.
Yeah, I mean that.
In a very prominent place.
Yeah, it's like on cheekbone.
The fun part about it is it's actually not covered by a mask.
It's like the one place on your face
Yeah.
that's not covered by a mask.
Yeah. My curling iron, don't worry, was only set to like 4,000 degrees when it touched my face.
Oh.
So.
Yeah.
Did you learn to ski the first time with my family? You did, right?
With you psychopath.
Yeah, with me and my family, though.
Yeah, but let me tell y'all about this. So
Mm-hmm.
you can decide if this is wrong or right. Not you, Sydney, because
I
it's
know what I
wrong
think
of you.
about it.
So I did learn with your family, and I remember I did the lessons. Like I did lessons
Mm-hmm.
with like the 8-year-olds and me.
Yeah.
No shame. I don't care.
No shame in your game.
So I did it. I went down like a bunny slope with you
Mm-hmm.
and your mom, and then like a one level up from bunny. I don't know what color that
Like
is.
green is one level up.
Like yeah, like a happy run.
Yeah.
Then Sydney was like, "Yeah, you're ready." Took me to the tippy top.
To be fair, you were a natural.
Incorrect. To the tippy top of the mountain.
Mm-hmm.
The place where surely nothing grows.
Birds don't fly there, maybe.
They don't. And then we had to do the skiing to get down.
Yeah.
On my first day.
It was your first day, but I feel like you had a really good time, number one.
Let me share this in all honesty.
Mm-hmm.
I did not have a great time until we stopped at that bar in like the middle of the mountain. And then I got a little drunk and I was like, you know what?
Yeah.
You have to die at some point.
Yeah.
But yeah, it was with you.
To be fair, I will say my mom and I had previously packed
Oh yeah.
a Camelback that was full of cider, hard cider. So you could have been on our level the whole time because that's how the Sproul family skis.
Like in the middle of the mountain, like take a break.
Yeah.
Sorry, I'm yawning because I am an old lady.
Was that when that man's skis fell?
Oh, yeah.
Okay. For our listeners, we were at this like a ski chalet bar situation in the middle of the mountain. And we were walking out and this man's skis fell down and he looked at me and he was like, "Aren't you going to pick those up?" And I wheeled around and I said, "Are you talking to me?"
She said it.
And he went, No, I'm not. And he shook his head like real fast, like, no, I'm not.
She said it like, "Are you talking to me?" Like that.
Yeah. He came into the situation hot.
Yeah.
He was ready to fight.
Then you were ready to fight.
Made a face that was like, yeah, let's go.
Let's fucking fight.
I'll fight with you.
Yeah. I love to fight.
I love a fight. And he was like, oh, no. I'm not ready for that.
Yeah.
So.
No.
You want to get into our interview today?
Yeah.
It's a good one. So the person we're interviewing today is Dr. Nesa Pittman. And if that last name sounds familiar.
And it should if you're a real Mal pal, because we interviewed her husband.
In season 1, I think?
Yeah, he's like our first interview.
So they are both incredibly intelligent and very cool.
She is a board-certified family medicine physician practicing in Austin, Texas. She went to UT Austin for her undergraduate degree, the University of Texas Medical Branch for medical school, and completed family medicine residency training in St. Louis, Missouri. She is a Texas native, born and raised in Houston. She describes herself as a foodie, enjoys spending time with her family, friends, and her 2 Boston Terriers, one pictured in our Instagram. Go check it out.
True.
Very cute.
Nesa is passionate about preventative medicine, patient education and advocacy, social justice, racial and gender equality in medicine, women's health, reproductive and contraceptive medicine, and teaching.
We love it. Welcome.
Dr. Nesa Pittman in the house.
Hi, everyone. My name is Nesa. My pronouns are she, her, and I am a family medicine physician practicing in Austin, Texas.
So let's start with some of the basics. What made you choose medicine as a career?
I was always drawn to medicine because I really loved science in general, and then I really found the human body fascinating. I was always interested in the idea of being able to educate, and I really liked communicating and working with people and trying to empower them about topics related to their health. And so it just seemed like a natural course that I would take.
So you're a family medicine doctor now. What kind of made you decide on that field particularly?
I chose family medicine because I really couldn't make up my mind on whether I just wanted to work with children or women or adults. I definitely enjoyed a lot of different rotations that I had during medical school. It was really between family medicine and OB gynecology. So I was really kind of going back and forth between the two because I really found just like the physiology and pathology of pregnancy to be so fascinating, especially like the higher risk pregnancies.
Oh, really?
So for family medicine training, you have 3 years of residency training. And for OB gynecology, it's 4 years. And if you wanted to subspecialize, for example, maternal fetal medicine, which is the high risk pregnancy specialist who manages those pregnancies, that would be like 7 years after medical school.
Yeah. Oh, wow.
That's wild.
Wow.
And just to do the math for people at home, in case you don't know, that's plus a 4-year undergraduate degree plus 4 years of medical school. Definitely a long road. Yeah.
So it was kind of like if I did want to still be able to take care of pregnant women and deliver babies, I still had my foot in the door as a family medicine doc. So it kind of still held that door open.
Yeah.
But in general, family medicine, it's broad spectrum, right? So it's cradle to the grave, or womb to tomb is another way to put it, because you can see, babies, children, young adults, pregnant women, adults, and geriatric or older patients. But most family medicine doctors, I think, tend to probably specialize in one area or another, or with one group of patients over another. I feel like as far as the old family medicine docs who were full scope and did everything, there's less and less of them now. And I think that more so in rural settings, when you're the only doc in town for like 150 miles.
Yeah.
Yes, you're it. And you manage everything and everyone.
Yeah. Have you specialized then within your field a bit?
I primarily, it's just a matter of like the patient population that you choose to see and that you choose to feel comfortable with. So for me, I knew that I wanted to take care of women, and I wanted to be able to do women's health. And so that's the difference too between an internal medicine doc and a family medicine doc.
Yeah.
They're both generalists, but the internal medicine physician only sees adult patients and doesn't see children, and some might, but typically don't do women's exams or women's health. Whereas a family medicine doc does.
I see.
I don't really see a whole lot of little kids. I primarily see like teens, adolescents, young adults, and then of course I do women's health. I do contraceptive care. I place IUDs and Nexplanons and remove them in my clinic practice.
That makes sense.
And of course adults and some older patients too.
Yeah. In that same kind of vein, could you tell us maybe the top 3 reasons that people come to see you?
Yeah, that's a good question. I think, I mean, in this day and age, it's been mostly COVID, right? So that's one of the
Fair.
top reasons for the past 2 years.
Mhm.
Yeah.
The other second reason is sadly depression and anxiety. I
Yeah.
do manage a lot of depression and anxiety. It's so common, especially just within the past 2 years. Everyone's really having a hard time, and
Yeah.
there aren't really enough psychiatrists, and it can take weeks to months to get in with them. So family medicine and internal medicine docs and pediatricians, I mean, the generalists oftentimes have to be the sub psychiatrist until their patients can get in with someone.
Yeah.
So that's definitely the second top reason.
Wow.
And then the third, in my practice specifically, because I'm still accepting new patients at my clinic. I've been there for a couple years, and we've had a lot of patients who've moved to Austin recently from other states. They see me for annual physicals and to establish care. So I have a lot of that as well.
Mm-hmm.
Stepping in with depression and anxiety, that feels like the weight of the world, right? I feel like that's everyone's top of mind. Just like to remind everyone, so they can go to their family doctor, right? To like get help for those things.
Absolutely. I think that's the hardest thing. The first step is to just seek help.
Yeah.
Yeah. Any primary care provider is definitely a great first step in being able to try and get help for your depression or anxiety or PTSD. Certain docs have, different comfort levels as far as how comfortable they are managing the spectrum of mental illness. I myself had a very vigorous residency training, and we managed a lot of mental health in my residency training. So I'm pretty comfortable. And so I do see a lot of patients that, have also insomnia or PTSD or, just kind of a variety of different types of anxiety, like panic disorder and things like that.
Yeah. Speaking about your residency, can you tell us a little bit about that? I just think your work there was so interesting, and your patient population. Tell us about where it was, what was it like, things like that.
Any doctor you come across will tell you that residency is like one of the most challenging and most difficult like years of their lives. So that's definitely true. My residency program was in St. Louis, Missouri. As a native Texan, when I got accepted into residency in St. Louis, that was a big change. I had never left Texas before, but I actually ended up really loving St. Louis and the people there. And I had a really great residency program, lots of support from our staff and our co-residents. It's variable depending on what your patient population needs. So there is like a standard curriculum of residency training for all family medicine physicians, but then the amount of exposure that you get in managing certain medical conditions might be very different depending on your patient population. And so for the most part, residency, medical residents do tend to staff clinics that primarily see uninsured or underinsured patients. And that was the case for me. And St. Louis does have a very large population of primarily African-American patients who are impoverished. And they have less access to healthcare. And so a lot of the focus of our residency program was on social determinants of health, which essentially really evaluates barriers that prevent patients from being able to take care of their health. That's anything related to their socioeconomic status. Do they have transportation? Are they literate? I mean, so many things go into social determinants of health. And so that can make it really challenging to try and help manage these patients. Someone who has uncontrolled diabetes, who doesn't have insurance, who can't afford their insulin and has to take 2 buses to get to their doctor's appointments. They're going to have poorly controlled diabetes. And it's not because they are not wanting to take their medication or not listening to what you recommend. It's because of these barriers. So that was definitely something we had a big focus on.
When you're thinking about social determinants of health and things like that, like how did that impact or how did that sort of shape your thinking as a physician?
I remember taking a quiz that Harvard University had developed about implicit bias.
Yep.
And I don't know if y'all have heard about this quiz before.
We've taken it, yeah.
Yeah. So that was, something that they had all of the residents do, which is very eye-opening. And essentially, it's kind of like these subconscious biases that we have towards people that kind of shape the way that we behave or act towards them or treat them, or our initial assumptions about that person. So, for example, it's a common bias or misconception to think that people who are overweight or obese are lazy. So that's an example of implicit bias. And so, one of the things that really stood out for me, particularly since my patients were mostly African American, was just how much racism played a role in their poorer health outcomes. And so that was really difficult to see. Like our Black patients had a lower life expectancy. Black mothers were more likely they had a higher risk or rate of maternal death during birth and labor. The Black mothers sometimes were more often screened for urine drug screening for marijuana use than Caucasian mothers or mothers of other ethnicities. So, just kind of seeing that and just seeing how much the healthcare system has all these really old policies that has shaped the way that we practice and treat patients. It was very eye-opening and very devastating, really.
Yeah, I believe that.
Did you see change in those systems while you were there, or have you seen it since?
Yeah, I think, with more education around these issues, in addition to implicit bias, racism in medicine, and socioeconomic determinants of health, I think there's definitely been a push towards having more of that training and education for physicians, so that, we can try and shape the future of medicine and how we choose to practice our patients and what policies that we try and support for them. There are some medical doctors who, they don't see patients, and their primary job is to actually, go to the state capitol and really try and provide information and education about policies that would really help benefit patients.
Yeah.
So there's a lot, I think, that people are trying to do. Of course, change is like at a snail's pace, though.
Yeah.
So that can be kind of frustrating.
For a regular everyday person who's not in the medical field, how can they or we advocate for change, or how can we kind of be allies in that?
That's a good question. It could be as simple as maybe just having those conversations and being curious to what a fellow friend's experience is in terms of their healthcare, be it, someone who is transgender, someone who is Black or Hispanic or other minority, and kind of just, learn about what their experience was. And then, of course, there's very valid mistrust of the medical system for African Americans because of the history of what the medical system has done, which I know you guys have kind of touched on in some of your other episodes. So I think, the awareness is one thing, trying to encourage people to seek medical attention for things that they're struggling with, especially depression and anxiety, which does run a lot higher in these groups of people, PTSD, trauma. or even certain organizations that you can join that could provide you with some information about policies in a language that you can understand, and be able to say this would be really good to support because this helps the safety network to help provide more resources for people who don't have insurance. Please call your representatives about this policy.
Yeah.
So of course there's that sort of action as well.
Yeah. That's so cool. Okay.
How has COVID changed your job, if it has, or it's changed everything?
She's shaking her head. No, no, I don't want to talk about it.
Oh, no. It's, gosh, it's been so hard. I think, there's absolutely a lot of burnout across the scope of medical providers, nurses, MAs, technicians, physicians.
Yeah, we hear that.
It's just been
the heavy sigh.
It's just kind of added to the burnout. Yeah. I think, any doctor or medical provider would probably tell you that we're also over it, and we're tired too. And, we worry about the fear of uncertainty.
No kidding. And then, so burnout is massive. Mental health is a problem for everybody. It's also a problem for medical practitioners.
Right.
I would imagine that mental health issues are probably equally as prevalent among medical practitioners as they are in the general population, if not higher.
Yeah, and it can considerably, also affect the way you practice and, the different health outcomes for your patients, your patient-doctor relationship.
Yeah.
So it can definitely cause other downstream effects if you're just not getting the help that you need.
Sure, definitely.
Right.
A lot of people who go into healthcare related positions or who go into medicine to become physicians are very typically type A perfectionists who really want to be able to achieve everything on their own, who have a lot of difficulty asking for help, and who are very critical of themselves and their shortcomings and their mistakes. And so that is also a perfect recipe for someone who can get burned out. So just trying to normalize the fact that it's so common.
That's good advice for everybody.
Yeah, for life.
Pivoting the conversation just a little bit, can you tell our listeners, as someone with XX chromosomes and reproductive female organs, are there screenings that you recommend? Are there screenings that you see people should get that they don't get? What do you think about? I know that well women appointments are one of the things that you're passionate about promoting. So,
yeah, absolutely. I always try and make sure that my patients understand and know what we do and why we do them. So, for example, the Pap test, a lot of women don't really understand why they have to get that done. They just know that they have to.
Yeah.
And so the Pap test is a way that we screen for cervical cancer or abnormal cells on your cervix. But that's one of the primary goals of the Well Women's exam. So the cervix is, kind of essentially the entrance to your uterus, and it can be infected by human papillomavirus or HPV, which is responsible for the majority of cervical cancer that develops. It's something over 95%.
Wow.
And HPV is a sexually transmitted infection, and it's not something that you can test for the way that you test for HIV or gonorrhea or chlamydia. So it's a sexually transmitted virus that can cause cancer, not just in the cervix, but it can also cause vulvar cancer. In men, it can cause penile cancer. It can cause anal cancer and head and neck cancer too.
Wow. Jesus Christ.
I know. And you think so the Pap test is a way that we screen for cervical cancer specifically, and we check to see if there's any abnormal cells on the cervix and if there's presence of the HPV virus. Kind of leading into HPV vaccine. So I'm sure a lot of women have probably heard of Gardasil. It's a type of vaccine that actually helps to prevent cancer caused by HPV. So it's definitely something that we really recommend. It's not something that's required for school, And so it is an optional vaccine. So if your parents opted out for it and you're an adult now, or if you're a parent considering whether or not you should have your son as well as your daughter, so either son or daughter, get the Gardasil vaccine. And I really encourage you to engage in a conversation about it with your provider or their provider, because essentially, we can't really cure HPV infection. And once you are exposed, there's always that risk of it developing into cancer. And so the vaccine essentially really helps to boost your immunity and your immune system's ability to be able to keep that virus under control to prevent it from causing cancer.
That's so cool.
Yeah, it's amazing. It's a great vaccine, and it's actually been approved by the FDA for up to age 45.
Wow.
For men and women. So previously, it was only approved up until the age of 26, and insurance would only cover it if you were 26 or younger. And we start providing it at age 11, and most insurances will cover it. And this is because of the research that has found that HPV has been involved in a lot of head and neck cancers in older adults, and a little bit more risk in men than women, actually, for the head and neck cancers.
Just a small plug for vaccines and science everywhere.
No kidding.
Other things to talk about, of course, contraception, very important. I know a lot of women are often very hesitant about hormones and birth control, and they're worried about side effects. And you see all these YouTube videos about, women talking about their experience of getting the IUD or the Nexplanon and how horrible it is. And, there's a lot of scary stuff out there, but honestly, contraception is an incredible invention. It's given women the power to be able to control their own reproduction so that they've been able to pursue careers and decide when they want to have children or if they want to have children. And there are a lot of different options, and the side effect profiles are very variable. So, one person's experience could be very different than another person's experience. So you kind of have to take other people's experience with it with a grain of salt, because you may not necessarily have those issues or those side effects. And there are a lot of really good, effective methods.
Yeah.
And honestly, pulling out is not an effective method. And if you are trying to do natural family planning, that can be effective, but it requires you to have very regular, consistent periods such that you can track your ovulation. And it requires you to do other things like checking your body temperature, checking the thickness of your vaginal discharge. I mean, there's more involved to natural family planning too, if you're going to take that route. So it's not 100% protective.
Yeah.
So, especially with Texas having changed their abortion laws recently, that's something I am always talking to my female patients about. If you are not wanting to get pregnant, please at least commit to using condoms 100% of the time if you are not going to be on contraception. And another thing about contraception is that even though you're on birth control, this does not protect you against sexually transmitted infections. So you still have to use condoms with new partners, or if you have multiple partners. And if you're inconsistent with condom use, at least get screening for STDs like once a year routinely. And that's something you could do at your well women's exam too.
Yeah, that's wild.
That's awesome.
Yeah. Could you tell us a little bit about what people should expect that most people don't expect during pregnancy?
Yeah. So, during my residency training in family medicine, we did several OB or obstetrics rotations. I have delivered a lot of babies, and have been.
How cool.
Yeah.
That's so cool.
It was really cool. We part of our board certification does include obstetric medical knowledge. So we are tested on this. That being said, I just want to preface that I'm not a formally trained OB gynecologist, and I don't see pregnant patients in my practice currently, but I can give some general information about pregnancy. One thing that I think is important and recommended for all women of childbearing age, which as long as you're having menstrual cycles, even if you're 48, you are a childbearing age woman who can still get pregnant, to consider being on a prenatal vitamin.
Yeah.
Now, the difference between prenatal vitamins versus regular multivitamins, really, I think it's just marketed as prenatal because they are having folic acid, which is the important vitamin. It's a B vitamin that is necessary very early in pregnancy when the fetus is first developing, and it helps to prevent neural tube defects. So it's very important that you have adequate folic acid. And obviously you can get it through food if you have a lot of leafy greens and vegetables and you have a really, really healthy diet, but it's always worthwhile to have at least 400 micrograms of folic acid, either in a multivitamin or a prenatal vitamin. And to take that once a day if you are wanting to get pregnant, or if you aren't really consistent with your contraception and you might accidentally get pregnant, just kind of as an insurance policy, taking that once a day. A study had found that for women who had taken a prenatal with folic acid and vitamin B6, just kind of like a combination, but primarily the folic acid, for about 3 months before they became pregnant, and while taking it through their pregnancy as well, had less symptoms of morning sickness and nausea and vomiting.
Oh,
That's all you need to tell me.
Right.
The neural tube defect didn't do it for you.
And as far as planning pregnancy, a lot of people don't know that actually having a successful fertilization and implantation of the embryo is very, very actually difficult in the body. I think, I don't remember the exact percentage, but it might be 25% or something like that actually
crazy.
implant per month, per cycle, per your ovulation cycle. So I know sometimes women who are trying to get pregnant, if it's been a few months and they've had unprotected sex and they have not had any success getting pregnant, don't worry too much, because oftentimes it takes a while. And typically we say that, unless you have any significant health factors like PCOS or diabetes, or you are older in age and these things can affect your fertility, after 6 months of unprotected sex and not being successful in getting pregnant, I would say that category of patients seek evaluation from their OB gynecologist. But for everyone else who's pretty healthy, we typically say to try for a year on your own.
Yeah.
And if you haven't been successful after a year, then you can come in and be evaluated. And a lot of the times too, women assume, oh, there must be something wrong with me. But actually, decreased sperm count and decreased sperm mobility is also a common cause of infertility too. So both men and women should be evaluated after a year of trying if they're unsuccessful getting pregnant.
Yeah, that's so interesting.
And I want to just put another plug for postpartum depression.
Yeah.
It's very, very common, and I think underreported and undertreated, and it can really impact the mother's relationship and attachment to their baby, and it can really just, be so difficult to suffer through. So, postpartum depression is very common. It's nothing to be ashamed of. It doesn't mean that you're going to be a terrible mother. So please do seek help.
That's great to know. That's a great plug too, because I feel like normalizing it is the way you get people to seek help for that kind of thing.
Mm-hmm. Or at least get people to start talking about it.
I probably sound so stupid, and that's totally fine. But you're postpartum depression, what can that look like? If I'm just a regular schmegular person, I have a friend who just had a baby, how can I be of help to them if I know what should cause alarm, or what could I do to help someone who, is suffering or living through postpartum depression?
That's a good question.
Yeah, there is a condition known as, postpartum baby blues, which is a common and temporary condition related to the decrease of your hormone levels after delivering your baby.
Because aren't they really crazy high and then they crash?
Yeah.
Psychotically. I heard numbers and I was like, that doesn't sound even real.
Yeah.
Anything.
It can be quite dramatic, because now that the baby is out of the womb, you don't need so much hormone to support the pregnancy. And so you do have a very dramatic decrease and leveling off of your hormones. And in that time, within the first few days after delivery, women can experience a lot of tearfulness, a lot of sadness, crying spells. But generally, those women also do have a sense of good connection with their baby. They are happy when they see their baby. They're concerned about the baby. Women with postpartum depression, the depression can really interfere with your ability to connect with the baby. Sometimes you might even just kind of feel a little bit detached or nonchalant towards your baby. And it's something that lasts longer. So baby blues can last, the first couple of days or couple of weeks after delivery, but then resolve on their own. And then you are back to quote unquote normal now that you have a newborn. So as normal as you can be.
Never normal again.
But postpartum depression typically persists if it lasts like longer than 4 weeks, 4 to 6 weeks, especially, or if it's, very severe, if you, after a couple of weeks are just are very withdrawn, are not really wanting to interact with the baby, are having, certainly any thoughts of harming yourself or my family will be better off without me, or any sort of thoughts like that, that's really big signs that you need to be treated for postpartum depression. And sometimes it's kind of challenging because it can be a spectrum of symptoms. So it could be as subtle as just lack of interest in doing things. And, a lot of times we kind of chalk it up to, well, I'm not sleeping because I'm breastfeeding, or having to get up to make formula every 3 hours overnight. And I'm just really tired. But so they can be really subtle, like just lack of interest, not really wanting to engage with friends or family, and kind of feeling a little bit detached from your baby, or just feeling a little bit sad. So it can be subtle and it can be severe. So there's that spectrum too.
Yeah, thanks. I was like, what do I look out for?
Yeah,
what do I need
totally
to be
fair.
on the prowl for?
Okay, I guess this is the part in any conversation with a doctor I feel like eventually goes to, what is your craziest medical story? Do you have any good crazy medical stories?
So in residency, we also did a lot of addiction medicine. So opiate addiction and heroin addiction specifically is at a very high rate, unfortunately, in the St. Louis community. So we very frequently had patients that we were trying to help who were addicted to heroin. We were prescribing Suboxone therapy. So we had a very, in-depth training in that as well. And I remember one day in clinic, they kind of like called for a doctor stat to the waiting room restroom because there was a patient who I think just shot up in the bathroom of our clinic and overdosed and was on the floor of the bathroom.
Oh my God.
So we had to, go and revive him. We fortunately, if you're going to OD anywhere, a doctor's office is the best place to do so. So we were able to,
the clinic.
I mean, not unfair.
We were able to revive him and everything. But that was a crazy day. And then
that's pretty crazy.
I feel like if that happens, everyone who responded gets just like a free day. Like, go home.
Yeah.
Just go home now. You don't have to come back.
Yeah, that's just like a Tuesday at my clinic.
Oh, heck no.
Yeah. So another patient I had more recently was this lady I had never seen before. And she came in and she was she came in for depression and anxiety. And she was talking to me about a stalker that she had. And I was, really concerned and asking her questions about it. But she truly believed that Jeff Bezos, the creator of Amazon, was stalking her.
Okay.
And she, was saying that she was saying that he calls her on the phone and has been taking pictures of her and has hidden cameras in her home, and that this is causing her a lot of stress and anxiety. And I was like,
of course.
Oh, you are acutely psychotic. Okay.
Yeah.
So this poor lady, she believed, these delusions.
Yeah.
It
was real to her.
It's very real to them. And it can be quite hard sometimes to treat those patients and reach those patients because, of course, they're very hesitant to seek medical care because they're like, I'm not crazy and you're just trying to,
Right.
Yeah.
you know, and so
You're part of it.
right.
Yeah.
So I try to, you know, encourage her to maybe let's start a medication, trying to kind of say, let's try and treat the depression and the anxiety symptoms. Can I refer you to a psychiatrist? Would you be willing to consider like a mood stabilizer? You know, I was trying to provide some treatment and refer her to get better help. But she was absolutely convinced that Jeff Bezos was stalking her.
That is so
And-
interesting.
I'm a little convinced too, actually.
I don't know that I could pick Jeff Bezos out of a line. Like, he's a
I
bald
couldn't.
guy.
I definitely couldn't.
If you put him next to Pitbull, I wouldn't know the difference.
Right.
You don't know who Pitbull? I would know who Pitbull was.
Unless he was wearing sunglasses. If you took the sunglasses off, Jeff Bezos and Pitbull are the same.
That is so fair.
That's so interesting. Wow. Poor lady. I hope she gets the help she needs, clearly.
I'm hoping she at
Hope
least
she did.
you know, followed up with the psychiatry.
So in 10 years, what do you want to be doing? And what do you want to have changed in medicine?
Oh, goodness. That could be like a...
I know. Loaded question. Solving the world's problems today.
Right. That could be like a whole podcast episode in and of itself. What would you want changed in medicine? I mean...
Yeah.
That's a great idea. It's a great idea. We'll have you back.
Yeah. Follow up.
So many things. Right. In 10 years, you know, I'd like to be doing some sort of teaching too. Like, I would really like to be able to have the opportunity to teach medical residents who are training in family medicine, or have opportunities to work with medical students who are interested in pursuing medicine. And then as far as things to have changed in medicine, I mean, I feel like, it also starts in education, right? So I wish that our education system did better about teaching everyone from a very young age about their health, like actually having a proper health education. And, you know, not just like not just like a video on you know, the menstrual cycle and that be it, or on abstinence and that be it, right? So I would really like to see just better health education for everyone, and better access to health, and just better ways to be able to provide good quality health without it being so expensive, which is, you know, obviously like the biggest issue, right? And there's a lot of different views and politics and controversy about what would be the best way to, you know, make medicine more affordable and more accessible for everyone. But the fact of the matter is that in this country, medicine is a privilege and not a right.
Yeah.
And I would really hope to see that change one day.
Yeah. For our non-US listeners, it's rough over here medically.
Yeah.
Mm-hmm.
Well, this has been amazing. You are super interesting to talk to. Yeah.
Yeah. A true beacon.
I feel like I've talked to you about some of these things
guys.
before, but I could talk to you about this all day.
Yeah, same here. It was really lovely to get to be a part of this and to have this conversation with you. So thank you so much for inviting me and for having me.
Thank you so much for coming. We have one last question before you go. We ask all of our interviewees, how do you take your coffee?
Well, I'm really more the person who takes a little coffy with my creamer.
Yeah.
Really.
I know that person.
Yeah.
It me.
Yes, I am that person. So, no, I'd like a good latte, and I mean, so basic, right? Pumpkin spice latte is one of my favorites.
Respect.
It's delicious.
Yeah.
No one can deny it.
No one can. No one should.
Right. Lots of sugar and cream, please.
Yep.
It's the best way to do it.
Not recommended daily. That's not a doctor's recommendation to have your coffee like that every day.
Fair enough.
Thank you so much, guys. It means a lot. I hope that your audience learned some interesting things and hopefully, you know, are more involved in being able to take care of their health.
Yeah.
Thanks so much. You're awesome. Hey, Mal Pals. Thanks for listening. If you haven't already, go follow us on social media. You can find us on Instagram, Facebook, and Twitter at Malpractice Podcast. You can also send topic suggestions, questions, or concerns to our email, malpracticepodcast@gmail.com. And just as a reminder, if you like what you're hearing, you should definitely subscribe, rate, and review us on Apple Podcasts, Spotify, Stitcher, or wherever you like to listen. And don't forget, malpractice makes perfect.